Thank you for your kind introduction. I'm going to talk today about perioperative blood product adjuncts. We've heard a lot today already about how much blood is used and how much FFP and cryoprecipitate and platelets are used. In the UK, 50% of our red cells and FFP are used for cardiac surgery and critically ill patients, and approximately 1/5 of all platelet transfusions go to patients after cardiac or during cardiac surgery. We've heard about all the attendant risks, and therefore the aim probably of looking towards using blood product adjuncts is to reduce that risk and potentially to reduce our allogeneic transfusion use. We've heard already a lot about the antifibrinolytics, DDAVP, and so today I'm really only going to concentrate on two things, which is fibrinogen concentrate, which has already been partly talked about, and PCC. We've also heard from Helen about the coagulopathy of blood loss, and so really my talk today is going to focus not simply on cardiac surgery, but on patients who have major blood loss. The coagulopathy that is associated with major blood loss is different in all of these patient groups. However, there are some sort of common ground, and what I really want to focus on is that if you are getting to a point of requiring major blood, or you have major blood loss, you get to having a breakdown of all your coagulation factors. If you lost your coagulation factors, including fibrinogen, many of your clotting factors, and the transfusion processes that we currently use tend to focus on giving back plasma-poor red cells, and therefore do not tend to give back clotting factors or fibrinogen replacement, and you get a dilutional coagulopathy. These are the reasons why we give FFP and we give cryoprecipitate, or we think that that's why we should be giving them. So what do we know about fibrinogen? Almost 20 years ago, Hipala did a study in major surgery and showed that during major blood loss, if you replace simply plasma-poor red cells to these patients, fibrinogen was the first coagulation factor to fall to critically low levels, to not be able to support hemostasis. Why is fibrinogen important? I'm sure you all know this, but I'll just go through it again. It's the final protein in the clotting cascade. It is the substrate for thrombin, and without fibrinogen being broken down into fibrin, stable clots are not formed. Not only does that happen, but fibrin is also a platelet activator. It helps platelet degranulation, and it binds thrombin and 10A, both two very important coagulation factors. It also binds plasmin. There's been an enormous amount of interest in fibrinogen over the last few years, looking at in major blood loss in all settings, and some of the recent guidelines on treatment of major blood loss have raised the fibrinogen level that you should have as a trigger from the standard 1 gram per litre that has been standard up until quite recently to 1.5 to 2, and I'll talk about why that might be the case. So how can we replace fibrinogen? In this country at the moment we do it with cryoprecipitate, but obviously fibrinogen concentrate is the other method of replacement, but as we have heard, it is not licensed in this country for anything other than congenital hypofibrinogenemia. There are potential pluses and minuses of cryoprecipitate and fibrinogen concentrate. Cryoprecipitate, they both come from pooled plasma and therefore both have the potential of transfusion-transmitted infection, but fibrinogen concentrate has a dual viral inactivation step which makes it somewhat safer. However, it is not completely without risk. Cryoprecipitate not only contains fibrinogen, and it is not known because no one has done any studies comparing fibrinogen with cryoprecipitate, whether these other clotting factors, so factor 8, von Willebrand factor, factor 13, whether they actually have a bearing on the hemostatic function of cryoprecipitate. However, fibrinogen concentrate is standardised. It comes in lyophilized little pots that can be kept anywhere up to the temperature of 25 degrees, so that's pretty helpful. And when you make it up, you can give it within 5 minutes. You also know what you're giving. Cryoprecipitate, although it has quite a high concentration of fibrinogen, is extremely variable because it comes from patients. The cost, however, cryoprecipitate at the moment this year is said to be £380 for 2 pools, so that's 10 units. Fibrinogen concentrate is £800 for 2 grams of fibrinogen. The cryoprecipitate in 2 pools generally provides somewhere between 3 and 6 grams. One of the first studies, and some of what I talk about will be trauma because that's what I'm most familiar with, one of the first studies that looked to see whether fibrinogen was important in patients when they were undergoing treatment for major blood loss was published 5 years ago that showed that if you give patients who are bleeding, trauma patients in the military setting, more fibrinogen in their massive transfusion protocol, they actually survived significantly more. I mean, it's an unfeasibly large improvement in mortality. However, it suggests that possibly fibrinogen is quite important. I just want to present some of the data that we have recently published, which is I'm involved in running an observational study at the Royal London and in Oxford, which is now European-wide, and we looked at the first 500 patients who came to our hospital with trauma, and these patients had not received blood products when we took the first blood sample, and they'd not received much in terms of crystalloid or colloid. And what we demonstrated was that in those patients that are bleeding, when they come in, their fibrinogen levels are significantly lower than those patients that are not bleeding. But what I want to draw your attention to is that actually the median level is above 1.5 when they come in. What we also demonstrated on multivariate analysis was that their admission fibrinogen level was an independent predictor of early and late mortality. And we've heard from Dr. Lester as well that in cardiac surgery, fibrinogen levels are predictors of bleeding, and we've seen that in the observational data from cardiac surgery and from obstetric surgery, that if patients come preoperatively with lower fibrinogen levels, they are more likely to bleed. What we also showed in our trauma patients was when we actually got those patients who were coagulopathic, and we diagnosed those patients with ROTEM. This is our typical trace of a coagulopathic patient who's got a low maximum amplitude at 5 minutes. If we took their blood and spiked it with different sources of fibrinogen, either cryoprecipitate or fibrinogen concentrate, we reversed the coagulopathy that we had in those patients. This was done ex vivo. It's not done in the patient, but it gives us a signal that potentially fibrinogen is quite important in these patients. So what evidence have we got out there in the literature that fibrinogen concentrate might be useful for patients? There's preclinical experimental data, in vitro data, which again Dr. Lester has presented, showing that if you have either a hemodilutional model where you dilute patients' blood and then give them fibrinogen, they actually improve their clotting ability. Or in pigs, again, if you give them fibrinogen and you subject them to trauma, their blood loss is much lower if they're given fibrinogen concentrate. Non-randomized trials, there are 12 of those. 2 of them are in cardiac surgery, but only 33 patients. In both of these studies, they showed a significant reduction in red cell, FFP, and platelet transfusions if those patients were given fibrinogen concentrate during cardiac surgery or after cardiac surgery. In the other 10 studies, there's a mixture of patient group there, and there's a mixture of conclusions from those studies, but in general they showed that if patients were given fibrinogen concentrate, then their blood product requirement was significantly lower. In all of these patients, there were very few thromboembolic events, but there are minimal number of patients so far. So what have we got in terms of randomized controlled trials? There's 3 at the moment, 2 that have been published fully, the first 2, and the bottom one is the largest of the 3, and this was presented at the ISTH last summer, where they looked at patients with cardiac surgery, and after cardiac surgery they randomized patients to either fibrinogen concentrate or placebo, and notably the fibrinogen was given on a ROTEM guided basis. So that's one method of actually looking at how to give it. And what it demonstrated was there was a significant reduction in transfusion requirement, 2 units in the patients that got fibrinogen concentrate and 13 units in the patients that were received placebo by the time it was 24 hours after surgery. There was no difference in thrombotic adverse events, but then there's only 60 patients. There were 3 deaths in the placebo group, all from bleeding. So safety of fibrinogen concentrate, this is a big issue. The largest data set comes from CSL Behring, which produced hemacomplatan, which is the most well-known fibrinogen concentrate. So 22-year pharmacovigilance data looking at over 1 million grams of this stuff being given. And they provide data of 3.48 thromboembolic events per 100,000 treatments. These patients are all comers, but the majority of them are congenital hypofibrinogenemia patients, and they may be different. A systematic review equally suggested that the safety was relatively good, but only looked at 228 patients. So I then went to have a look at clinical.gov website to see how many RCTs are currently ongoing, and there are 8. They're looking at, they should all be completed in the next 2 years, and there are about 800 patients. 4 of them are in adult cardiac surgery, 2 of them in paediatric cardiac surgery, and they are all looking at fibrinogen concentrate versus placebo. They all have common endpoints: how much blood product exposure do patients get, and how much blood loss is compared between the 2 arms. And then they also all look at thromboembolic events. What none of them do is look at mortality, because none of them are big enough, and therefore, they will give us a signal about how good they are at reducing blood loss, but they probably won't be able to tell us very much about mortality. So moving on to PCC. PCC is potentially a replacement for FFP, and we've heard that there are relatively few indications for actually giving FFP to patients. Systematic reviews have demonstrated this from over 80 RCTs. So why might we be giving PCC? And there are 3 reasons. One is for oral anticoagulation reversal, and the reason why I've put it up there is because although this is cardiac surgery conference, it's really the only indication that I could find very much evidence about. The second is for treatment of dilutional coagulopathy, so for patients that are having major treatment for major blood loss, and for those patients with hepatic failure. So just to run through what is in PCC, basically again it's a pooled plasma product, and so therefore has a minimal risk of transfusion transmitted infection, because again it has a dual inactivation viral process. It contains factors 2. In this country there are 2 types of PCCs. In this country there are 4 factor PCCs, and in other countries there might be 3 or 4 factor PCCs. But in the UK they're all 4 factor. They have factors 2, 7, 9 and 10, and also contain proteins C and S, antithrombin and heparin. The standard dose of approximately 2,000 international units comes in 80 mils, and again it could be made up at the bedside and is stable up to 25 degrees C. Problems with it are potentially thrombosis and potentially disseminated intravascular coagulation. The cost of it is not as much as fibrinogen concentrate when compared to FFP. So the most information that I could find looking for the use of PCC was for warfarin reversal, and it makes perfect sense really. Warfarin is a vitamin K antagonist, limiting the amounts of factors 2, 7, 9 and 10, and PCC contain those factors. And what it's demonstrated in all of the studies is that giving PCC, you reverse your warfarin much more rapidly, much more effectively than FFP, and you reduce bleeding episodes. What I just want to mention for non-haematologists, that if you give FFP, your factor 9 level does not, even if you give decent doses of FFP up to 20 international units per kilogram, your factor 9 levels do not ever get to a hemostatic level, and we do not recommend giving FFP for warfarin reversal because it doesn't work. But the only thing to say is that none of these studies have a standard dose. We don't know what dose we should be giving. Nobody has agreed on that, and it's very difficult. People are suggesting that we should be dosing by the INR of patients, but it is currently unclear as to how we should move forward with that. And there are no mortality data to compare PCC with FFP, and so as yet, we still can't say there is a mortality benefit using it. For dilutional coagulopathy, so again, in the setting of major blood loss in trauma or in surgery, there are preclinical studies, both in cardiac surgery and in trauma in pigs, that show if you have a pig and put it under cardiopulmonary bypass and you then give it PCC, your factor levels return to normal, but we've already been shown that they don't necessarily fall that far anyway, but that skin bleeding is normalised. In trauma, when you dilute pigs with starch and then you give them PCC and you compare that to standard dose FFP or high dose FFP, your PCC achieves hemostasis much more rapidly than FFP does, and your blood loss is significantly lower. So what have we got in man? Not very much, really. There are no randomised control trials at the moment, and most of the studies are in trauma, and all 3 of these are done by the same group. And equally, all 3 of the studies had patients in the intervention arm receiving fibrinogen concentrate as well as PCC. Again, the PCC is given on a ROTEM-based algorithm, so if your clotting time is prolonged, you got given PCC. But all of the patients that receive PCC also receive fibrinogen concentrate, and it's therefore very difficult to separate out which one of these actually helped the patient. There is one study that was a retrospective series that looked at liver disease patients, about 200 patients, that showed that PCC stopped the bleeding in all of these liver patients, but that's about as much information as we've got so far. Safety of PCC in animal models, there was one study that was published last year that demonstrated that if you give a high dose of PCC, so 50 international units per kilogram, 100% of the pigs that were treated with injury got thromboembolic disease, both arterial and venous, and 44% of them developed DIC. However, in patients in a systematic review that looked at 460 patients, the thrombotic complication rate was 1.5%. I looked again to see whether there are any ongoing RCTs that might inform us in the next couple of years, and there are only 2, and both of these are looking at the reversal of warfarin and looking at PCC versus FFP for either intracranial hemorrhage or for bleeding. One of these is completed and we're waiting for the results of that. So very limited evidence at the minute, but something that no doubt we will find out about in the next few years. So conclusions. Fibrinogen concentrate and PCC both have potential and sort of intuitively would be the way forward, but at the moment the evidence base that we have is relatively limited. It will hopefully come out in the next few years, particularly about fibrinogen concentrate, but at the moment we can't really say what the optimal dose or how we should be, what are our triggers, and should we be using TEG and all of those things, so those questions are still unanswered. Thank you.
Are there any questions?
I have a question. What is the likelihood that these will simply become the new factor 7?
Well, yeah, that is the issue. And certainly if you listen to Ian Roberts, that's what he would say. And I think with fibrinogen concentrate, hopefully, well, I hope we'll have some answers. I mean, I hope it won't, and I hope we've learnt our lesson from the fact that with recombinant 7A, we all jumped in and said, yes, it's going to make everyone better. Clearly, fibrinogen concentrate may have a role, but actually we are moving to randomised control trials quite early, and hopefully we might get an answer. I don't know.
have a second quick question.
Okay.
If, as some of your evidence suggests, there's actually not the coagulant pathways that are deficient, but it's overactivation of the anticoagulant pathways. Potentially. Why do we think that we're giving them fibrinogen will improve outcome?
I think because it's a substrate for the end of the coagulation pathway. It stabilizes platelet function. It enables what platelets are left there to actually do their job. And it also can reduce your fibrinolytic, your susceptibility to fibrinolysis if your fibrinogen level is slightly higher. I don't know. I'm making it up.
Okay. That's fantastic. Thank you.